This question appeared in NEET PG 2022 and it talks about a 74-year-old patient with CAD who presents with palpitation and the ECG is given below. The blood pressure is mentioned as 120 by 84. So what is the best possible treatment for this particular patient? And your options are A. Oral metoprolol, B. IV metoprolol, C. Oral amiodarone and D. IV amiodarone. Now, this is a very important topic from exam point of view, and the ECG also is very important. So let's understand the ECG. So the first thing you can very easily, see is the wide QRS complexes. Okay, so the QRS complex is wide. You can see wide QRS complexes. All these are wide QRS complexes. Okay, so the morphology of QRS complexes is distorted. It's a wide QRS complexes. Let's look at the heart rate. So how do we calculate the heart rate? We can see, the distance between two QRS complexes in large. If you see the large boxes and divided by 300. So if you see here, two large boxes are there. Okay, between two beats. Okay, so we use the formula 300 by 2 because we are calculating the large boxes. If we calculate the small boxes, it will be 1500, but because we are calculating large boxes, so 300 by 2, so the heart rate is 115. This is your heart rate. So obviously the heart rate is increased, we are having tachycardia. Okay, the next important thing I want you to understand is that is there a change between beat to beat QRS morphology? Is there a change between the two different beats? The QRS complex, the morphology of QRS complex, is it changing between beats? No, they are same. So what we have is something called as sustained monomorphic ventricular tachycardia. Very easy for you to diagnose. So we have a patient of sustained monomorphic ventricular tachycardia who is hemodynamically stable, because in the question it was mentioned as 120 by 84. The blood pressure was stable. However, he had some history of CAD. So this is, once we have the understanding of this, let's first understand how do we approach the management of these patients. How do we approach a patient who is having ventricular tachycardia? Sustained monomorphic is just one subtype, but any patient of ventricular tachycardia, how do we approach it? So the first thing, whenever a patient of ventricular tachycardia comes to you, the first question which you have to have is about hemodynamic stability. Okay, let's say the patient is hemodynamically unstable. So you have a hemodynamically unstable patient. So how do will in the question they will talk about hemodynamic instability or instability? They may talk about hypotension. Okay, they may also mention about impaired consciousness or unconscious patient. They may talk about symptoms of signs and symptoms of pulmonary edema. Okay, so these are the ways they will indicate the patient is hemodynamically unstable. So if you have a hemodynamically unstable patient, you should simply go for a QRS synchronized DC cardioversion. Because the patient is unstable hemodynamically, you have to immediately try to revert the cardiac rhythm to normal. So that is why you go for an immediate QRS synchronized DC cardioversion. Let's say we have a hemodynamically stable patient. Then the next question you are going to ask yourself is, does the patient have any structural heart disease? Okay, if the patient is having any structural heart disease, if the patient is having any structural heart disease, okay, then your drug of choice will be IV myodarone. Okay, let's say the patient is not having any known structural heart disease, then you may give a trial of IV adenosine, or you can put the patients on beta blockers like metoprolol. Beta blockers are also preferred in patients who are young, young adults or young patients or children. These we will prefer beta blockers. Okay, so this is how, if a patient is hemodynamically stable and if he is having structural heart disease, then you will go for IV amiodarone. If he does not have any structural heart disease, then you may go for a trial of adenosine or may put him on beta blockers. Now, let's say after this, once you have reverted back to the normal rhythm, you will admit and obviously investigate the patient further and decide on the further management. Let's say you have a patient who is having recurrent episodes of ventricular tachycardia. What will you do? So you can put him on antiarrhythmics, or you can go for catheter ablation. Okay, you can go for a catheter ablation. Now, what can we do for patients who have ventricular tachycardia and have some structural heart disease? Okay, so they may have some various very life threatening ventricular tachycardia. So here we will go for implantable cardiac defibrillators, also called as ICDs. Okay, so this is how you will approach the management of any patient who is having ventricular tachycardia. In this case, we have already seen. So let's go back to the question. We have seen that there is QRX complex which is widened. We all have heart rate of around 150. We have a stable patient, but there is a history of CAD, so probably he may have some structural heart disease because of there may be some ischemia, myocardial infarction, fibrosis, something like that. So in that case, our drug of choice will become IV amiodarone. Okay, in that case, and he's an old patient also, so that all will move our management towards IV amiodarone. So again, this ventricular tachycardia is a super important topic from exam point of view. You have been given ECGs to make a diagnosis. In this case, the management was asked various clinical scenarios, and based on the clinical scenario, you have to decide the appropriate management for these patients. Very, very important topic. You can easily expect one question in any PG entrance examination on ventricular tachycardia.